How's it going, guys? We have a medium difficulty question for 2CK, internal medicine, family medicine. If you're studying for step one, you need to know this ECG, and I'll tell you some important factoids. So, 71-year-old man, he just comes in for health maintenance examination, reports occasional lightheadedness, otherwise no past medical history, walks the dog 4 days per week, 30 minutes at a time, blood pressure 130/80, fasting blood glucose 90, should be 72 to 99, 100 to 125 is impaired fasting glucose, 2 fasting glucose is 126 or greater, diabetes mellitus, any 1 random fasting glucose 200 or greater, diabetes mellitus, HbA1c 6.5 or greater, diabetes mellitus. Lungs are clear to auscultation in addition to metoprolol beta blocker, which is the most appropriate initial pharmacologic therapy. And then we look at the ECG here. The pass level component is that you know that this is atrial fibrillation. The two things you're going to see on ECG, number one, that the QRSs are random intervals apart from each other in terms of their spacing. We call it irregular rhythm. The second thing you're going to see is absent P waves prior to the QRS complexes. So atrial fibrillation, and then how do we manage it? Okay, so let's just whip through the answers. Choice A, aspirin, correct answer. Now, there's something called the CHADS score. There's different variants of it, CHADS2 VASC, etc. I can tell you that for USMLE, the simple CHADS2 score suffices. And they probably do that because they recognize that there's variations of it across institutions. And this is going to determine the type of blood thinning we need, whether antiplatelet aspirin or whether anticoagulation such as warfarin. Okay, so CHADS score. So C is congestive heart failure. There's no evidence of that here. We don't have pedal edema. We don't have JVD for right heart failure. The lungs are clear to auscultation, no left heart failure. And then I went out of my way anyway to say, OMG, he walks the dog 30 minutes at a time, just to emphasize that even with exertion, there's no evidence of heart failure. H is hypertension, which he doesn't have here, greater than 140/90. Age greater than 75. Okay, that's the one that people forget. They think maybe 65, 70. It's 75 or greater. So each of these are a point if you have them, and he has 0 points so far. And then D is going to be diabetes, which he doesn't have. I just explained. And then S is stroke, refers to stroke, TIA, or any embolic phenomena, such as acute limb ischemia as well, or acute mesenteric artery ischemia. So he's got 0 points of the CHAD score. So if it's, and the latter, of course, is 2 points. That's why it's called CHADS2 score. So if you have 0 or 1 points, you get aspirin, which this guy does. And they're known to do this on 2CK. They just give aspirin straight up, okay? So antiplatelet therapy. If you have 2 or more points, you get warfarin. Now, some students get pedantic about, are we giving warfarin because we have valvular AF versus can we give novel agents, the new age or novel oral anticoagulant agents, NOACs, such as dabigatran or apixaban. These are agents that could be used for non-valvular AF. USMLE doesn't give a fuck. They're old school. Warfarin will be the answer if they want anticoagulation. So we don't have 2 or more points here. Now, USMLE is pretty much not going to be borderline about it. They're not, and this also factors into because they have variations of the CHAD score. In other words, they're not going to dance on the line. They'll either give you this situation where the guy has no risk factors of CHADS apart from atrial fibrillation, or the dude will have all of the risk factors. It'll literally be, yeah, he's got evidence of heart failure, he's got hypertension, he's 77, greater than 75 years old, he's got diabetes, and he had a TIA last year. Okay, like they make it very easy that way. And the answer would just be warfarin where aspirin's wrong. Okay, now here I threw in heparin as well as a distractor. And I mention this because USMLE is not going to throw heparin and warfarin at the same time where you're forced to say, oh wow, we have to bridge with heparin first. They're not going to do that. And I've seen students get questions wrong with CHAD score as a result, where they don't choose warfarin because they're like, oh, well, wouldn't we start with heparin first? Yeah, we would technically, but it's still warfarin if you have an elevated CHAD score 2 or greater. Okay, so that's how we manage the blood thinning with atrial fibrillation. And then everyone with AFib is also going to be managed with rate control first. Now, beta blocker tends to be what they use first. USMLE doesn't care about the specifics as far as which drug and why. That's just per my observation. They're not going to say, oh, the patient has severe asthma history, and that's why we don't give a beta blocker. We give verapamil instead, or history of severe depression, so we want to avoid beta blockers. They don't do that, okay? So they like just aspirin versus warfarin for CHADS. They're not going to focus on the actual AFib management, which is rate control before rhythm control. But I'm just telling you, you watch this clip that, as I just fucking said, we do rate control before rhythm control. So we might do beta blocker, we might do verapamil. Those are rate control. If the patient fails it, we can go to flecainide, which is the first line agent for rhythm control. This is something that shows up in step 3 material for whatever reason. No evidence that it actually shows up on the real deal. It's a factoid you could know, because when you're studying drugs, so type 1A antiarrhythmic, and you're like, oh wow, flecainide, when would we use that? It's the first line agent for rhythm control in AFib, and the patient must have normal structural heart disease, so no evidence of left ventricular hypertrophy, no coronary artery disease, so there must be no ischemia. Okay, we're talking level medicine 301 level details here. I'm just telling you when flecainide could be used, first line agent for rhythm control in AFib. Clopidogrel, wrong fucking answer. You'll read that this is classically used for stenting procedures. USMLE doesn't even give a fuck about that indication. Okay, like they like this for carotid stenosis. Okay, so for peripheral vascular disease as well, arterial disease, the patient needs to be on a triad of number 1 statin, number 2 ACE inhibitor or ARB, and number 3 antiplatelet therapy, where it can be aspirin alone. They like that. Oftentimes just aspirin. It can be the combo of aspirin dipyridamole. It can be clopidogrel alone. And also clopidogrel is the second drug we give after an MI. Okay, so the first drug we give is aspirin following an MI, and then paramedics arrive, and then we give clopidogrel, dual antiplatelet therapy. Okay, we add clopidogrel on top of it. It's an ADP2Y12 receptor blocker, and so this is going to be a drug that also, same mechanism, ticagrelor, ticlopidine, prasugrel. What was going through my mind for a second is that, and it's tangential, is that cilostazol is a drug that's used for intermittent claudication. Okay, but I've made plenty of clips on that. Wrong fucking answer. You know the deal. To make more content, if you like my stuff, subscribe my channel. I appreciate your time. That's it.